Hi, my name is April Glasper, the current P3, and I will be presenting my EBM Journal Club. So my journal club was entitled Clindamycin versus Bactrim for Uncomplicated Skin Infections. The main authors include Miller, Dom, Creech, and Young. It was funded by the National Institution of Allergy and Infectious Diseases, the National Center for Advancing Translational Sciences, and the National Institutes of Health. So the background. The background of the article basically says that skin and skin structure infections are common in ambulatory settings. However, the efficacy of various antibiotic regimens in the area of community-acquired MRSA is unclear. So the objective of the study was to compare the efficacy of Bactrim and clindamycin for the treatment of MRSA. There is no current exact regimen in terms of treating MRSA, but Bactrim and clindamycin are most often used because they do have activity against MRSA and they have a low cost. The trial design was randomized, experimental, and double-blinded. And basically, randomization helps avoid bias in assigning patients to either the Bactrim group or the clindamycin group. And also, double-blinded study is a study where the information in the study is kept from both the tester and subjects. There were 4 locations where patients were recruited, and they included the University of Chicago Medical Center, San Francisco General Hospital, Harvard UCLA, and Vanderbilt University. The inclusion criteria included patients who were outpatient with uncomplicated skin infections such as cellulitis, abscesses larger than 5 centimeters, or both. It also included patients who had at least 2 of the following symptoms or signs for at least 24 hours, and those symptoms or signs included swelling, redness, tenderness, pain, warmth, and drainage. The exclusion criteria, there are a lot, so I will not go through all of them, but some of them were patients who had superficial skin infections such as impetigo, skin infection at body sites that required specialized management such as genital or hand infections, people who had a high fever, who were immunocompromised, and patients who had received antibiotic therapy for staphylococcal activity in the past 14 days. In terms of subjects, throughout the study there was a total of 524 subjects, and once again the locations were recruited from were urgent care centers and emergency facilities. Patients were divided into 2 groups based on the characteristics of their infections, and the 2 groups that patients were divided in were patients who had large abscesses or cellulitis, or the other group was patients who had small abscesses. And the reason why this was done was because in the article the results were basically for the large abscess cellulitis group only, and each group had a different treatment based on the abscess size. The primary endpoint and secondary endpoint. So the primary endpoint basically was that the cure rate in terms of clindamycin was 80%, while in Bactrim it was 77%, and that was in the intended to treat populations, and that was a difference of 2.6%. But in the population that could be evaluated, the rate of cure was 89.5% in clindamycin and 88.2% in the Bactrim group, with a difference of 1.2%. For the secondary input, the article didn't really address any secondary inputs. It just mainly focused on the treatment of MRSA with clindamycin and Bactrim. There was a follow-up. It was 1 month after the end of treatment, and this actually gave the study an advantage because other studies lack a follow-up. The duration of treatment itself lasted for about 12 days. The test to cure was done 7 to 10 days after the end of treatment, and I stated before there was a 1 month follow-up. In terms of population, there was a total, the female population was 52.3%, while 52.3% of the patients that were looked at were male, while 50% were female. 53.2% were black, 40% were white, and around 28.6% were Hispanic. The average age was about 27 years, and 30% of the patients who were also looked at were children. And there was no significant differences between the groups. In terms of our arms, 264 patients were given clindamycin and 260 were given Bactrim. In terms of statistical analysis, the null hypothesis was that clindamycin and Bactrim would have equal rates of cure. The study was designed as a superiority trial, which is a test that detects the differences between treatment with a 80% power to detect an absolute difference between the two treatment groups. Studies that were used for comparisons were Pearson's chi-square test, Fisher's exact test, or an analysis of variance test. And all tests were two-sided. And last but not least, interim analysis for safety were performed by an independent data and safety monitoring committee. In terms of our results, so in terms of our baseline characteristics, females on Bactrim were 121 subjects, and on clindamycin there were 129. 188 non-Latino patients were on clindamycin, and 86% were on Bactrim. Not 86%, but sorry, 86 were on Bactrim. Bulk of the patients in terms of race were white and black. In terms of age, bulk of the patients were greater than or equal to 18 years of age, and the types of lesions that were mostly seen were cellulitis only, but there still was a significant of abscesses and only a few mixtures of the two, meaning the patient had a mixture of cellulitis and abscesses. Primary endpoint and secondary endpoint is the same as I said earlier. In terms of adverse events, clindamycin and Bactrim adverse events were similar. The most common adverse events were diarrhea, nausea, vomiting, itching, and rash. There were no cases of Clostridium difficile associated diarrhea. And with the author's conclusions, the author basically concluded that they found no difference between the use of clindamycin and Bactrim in terms of their efficacy or side effect profiles for the treatment of uncomplicated skin infections, including cellulitis and abscesses caused by MRSA. Now with my critique, I think some of the strengths of the study was the trial designs they used, which again was randomized, double-blinded, and experimental. This was good because it eliminated the chance of bias. Other strengths was that they were very diverse in who they studied based on race, gender, and age. We had pretty much everybody looked at in terms of all these categories that I just listed. Weaknesses, I think one of the main weaknesses was the inclusion of patients with serious health ailments or conditions. Once again, MRSA doesn't just target healthy people, it can target people who are immunocompromised or have other health ailments. And I think it's important that we look at them because immunocompromised people are at a higher risk of developing greater mortalities associated with MRSA because they have a weak immune system. So we need to look at how MRSA should be treated in those patients. Also, another weakness was the fact that only two antibiotics were looked at, and I believe that was just due to the lack of known coverage, MRSA coverage by various antibiotics. And lastly, the doses were not well defined. In terms of our primary literature, the primary literature was taken from the New England Journal of Medicine, and this article came out in March of 2015, so it is relatively new. And once again, with the application conclusion, the authors concluded that there was no significant difference between the uses of clindamycin or Bactrim and the treatment of MRSA-induced uncomplicated skin infections in children or adults with few or no major coexisting conditions. And once again, my name is April Glasper, a P3, and that is my journal club. Thank you.